Understanding Dementia, Myths and Treatment Options. It's helpful if you spend just a couple of minutes thinking about what you've heard about dementia that you think may be untrue, or perhaps some things that you've thought were true before you heard the previous sections of the Understanding Dementia. In the next few slides, we're going to look at some myths about dementia. Dementia is not strictly a genetic disorder. Familial Alzheimer's disease, sometimes referred to as autosomal dominant Alzheimer's disease, is genetic. It accounts for less than 5% of all cases diagnosed. It tends to cause young onset Alzheimer's disease and primarily diagnosed between the ages of 50 and 60, but can be diagnosed even earlier. The vast majority of people with Alzheimer's disease are diagnosed with sporadic Alzheimer's disease, which means that there is no direct identifiable cause. Not all genetic conditions are caused by a single gene and show clear patterns of inheritance. However, they may be linked to changes in multiple genes that create an increased susceptibility for developing the disease. For example, people who carry the APOE4 gene have an increased risk for developing Alzheimer's disease, yet many people who carry this gene do not go on to develop the condition, suggesting that there must be other physical or environmental factors involved. For example, head trauma, nutrition, other medical conditions, exposure to toxins, and the list goes on. Sometimes people are concerned about a family history of Alzheimer's disease when, in fact, they have a family history of dementia due to different causes, for example, cardiovascular disease or diabetes. Dementia is not a natural part of aging. Although age is the most significant risk factor for developing dementia, it is not natural or normal to develop dementia as we get older. There are absolutely changes that we can expect to experience as our brains age, just like there is with our joints, our bones, our skin. However, as mentioned earlier, dementia is caused by diseases that damage the brain tissue, not caused by aging. Our risk of developing certain cancers, osteoporosis, arthritis, etc., all increases with age, and so too does our risk of developing dementia. However, many people live to be old, very old, with no signs of dementia. So while age is the most significant risk factor, individuals in their 30s and 40s can also develop dementia. While rare, it does happen. So the myth that this is an old person's disease is untrue. Dementia is not preventable or curable. Currently around the world, there are research studies looking into the causes of various types of dementia. Because the exact cause of the various types of dementia is yet unknown, we don't know how to prevent it. Research does indicate there are a number of risk factors other than age and genetics that could put people at higher risk of developing dementia. These include diabetes, hypertension, obesity, poor nutrition, smoking, social isolation, among others. There are also a number of protective factors that may help reduce the risk of developing dementia as we age. These can include physical activity, cognitive and social activity, education, and protecting the head against trauma. Important to note that these are protective, not preventative. There are some claims that certain foods, supplements, or natural health products can prevent dementia or reverse the damage caused by dementia. At this point, there is no conclusive evidence from research to back up these claims. It is not caused by aluminum or vitamin deficiencies. Aluminum was a major focus of research in the 70s to 90s. Some researchers are still looking at the potential link between aluminum and Alzheimer's disease. There is no convincing evidence at this time. Aluminum in its non-metallic form is found everywhere. Because it's in the earth, it occurs naturally in the foods we eat. It's naturally found in drinking water and in some municipalities as an additive in the water treatment process. Aluminum is present in the body, but its role is not fully understood. Very little of the aluminum taken in by a healthy individual is actually absorbed. Most is flushed out of the body by the kidneys. Aluminum has been studied for over 40 years as a substance that might be linked to Alzheimer's disease. Dr. Diamond's research report for the Alzheimer's Society of Canada, the report was released in 2011, stated the following. Researchers are still examining whether some people are at risk because their bodies have difficulty handling foods containing the metals copper, iron, and aluminum, although most researchers no longer regard aluminum as a risk factor for Alzheimer's disease. Severe dietary deficiencies, for example B12, and abnormally high or low levels of potassium are tested for during the diagnostic process and may be related to delirium. Dr. Diamond's research report stated that there are some research studies linking low intake of vitamin D, folate, B6, and B12 to potentially increased production of amyloid beta. But there was no clear link between this claim and the development of Alzheimer's disease. Dementia does also not mean that the person will no longer have a meaningful life. You may have seen Jim Mann's story on our website, and if you've not yet seen the Jim's Story video, I encourage you to Google Jim's Story along with the words dementia or dementia-friendly communities. Jim Mann and many others embody continuing to contribute in meaningful ways to their family or community after a diagnosis of dementia. People living with dementia have served and continue to serve on both the provincial and national Alzheimer's Society's boards of directors, have worked with us as passionate advocates for dementia strategy in BC, have served as honorees for one of our annual Walk for Alzheimer's, or have just spoken candidly to their families, their friends, their own communities about living with dementia as a way of battling stigma. It does not mean that the person will become violent. While some people with dementia do react or respond to stimulus, to triggers, in ways that may seem aggressive, it's important to acknowledge that not everyone with dementia becomes violent. Oftentimes, caregivers, we can control the triggers of responsive or reactive behaviors so that the person does not respond aggressively. This will be discussed in more depth in the Understanding Behaviors webinar that you can find on our website. It does not mean that the person will no longer understand what is happening around them. There are two language areas, one responsible for language in and one responsible for language out. Not everyone with dementia experiences deficits in both areas, so they may very well be able to understand what is being said around them and about them, even if they have difficulty producing a response. Understanding Communication, the webinar can be found on our website, is worth reviewing for more information about communication and dementia. The main thing here to remember is that it's important not to talk about a person with dementia in front of them like they are not there. Include them in conversations as much as possible. As many of our families and people living with dementia tell us, nothing about us without us. If you have watched the What is Dementia session, you will have already seen this slide, but the information also fits in here and it bears repeating. Only doctors are able to diagnose dementia. Diagnosing dementia involves a process of ruling out other things, including those conditions that cause delirium. Doctors may also assess the person's functioning by conducting a cognitive assessment called a mini mental state exam, the MMSE, or a Montreal Cognitive Assessment, a MoCA. These tests are scored out of 30, and they're designed to test different types of memory and thinking abilities, such as visual spatial awareness, short-term memory, language, and orientation. Neuroimaging may also be ordered to help determine if there are signs of the brain shrinking or if there are signs of a stroke. It's also important for doctors to hear from family members about the kinds of day-to-day symptoms and changes that family members are noticing. A good way to do this is by keeping a journal and making a copy for the doctor to read ahead of time. Take detailed notes about the things that you have noticed or that you have experienced yourself that are concerning to you. Simply telling the doctor that you are worried about your memory, for example, is very different than sharing that you recently got lost coming home from the grocery store because you couldn't remember which way to turn at the stop sign and nothing looked familiar. In the same vein, there's a difference between saying that you forget words versus saying that you have trouble discussing things because your vocabulary seems to be shrinking, or that you can no longer do the crossword puzzles at the level that you formerly could. We all forget things and words sometimes, but a healthy aging adult should not experience a reduction in the size of your vocabulary. It can take some time to wrap our thoughts around what all this means. You can continue to reflect on this and what you've noticed and make some notes for the next time you visit with your doctor. There's currently no cure for Alzheimer's disease and other dementias, nor is there any treatment that will stop the progression. Several medications are now available to treat some symptoms of Alzheimer's disease and other dementias, such as memory decline and changes in language, thinking abilities, and motor skills. The treatments work for some people and not for others. There's two broad families. Cholinesterase inhibitors are available in Canada to treat symptoms in people with mild to moderate Alzheimer's disease. They are sometimes prescribed for other types of dementia as well. They are donepezil, brand name Aricept, rivastigmine, brand name Exelon, and galantamine hydrobromide, brand name Reminol. Cholinesterase inhibitors help by improving the ability of impaired nerve endings to transmit messages from one nerve to another. Eventually, nerve endings degenerate and the drugs are no longer effective. These drugs are prescribed for people with mild to moderate symptoms. Donepezil has been approved for mild, moderate, and severe Alzheimer's disease. The second type of drugs are NMDA receptor antagonists. Memantine hydrochloride, brand name Ebixa. This drug has been approved for individuals with moderate to severe Alzheimer's disease, but it is not covered by pharmacare. Information is passed from one nerve cell to another by chemicals called neurotransmitters. As Alzheimer's disease progresses, the neurotransmitter glutamate leaks out of nerve cells and is reabsorbed at levels that are toxic to the cell. Memantine hydrochloride works by blocking the reabsorption of glutamate into nerve cells. Researchers continue to search for treatments and cures. Quality of life studies and clinical trials are happening in BC and around the world. In the More Information link below this video, you'll see a link to a downloadable document that contains links to a whole number of helpful resources, including print resources that you can download. Also, on the Alzheimer's Society website at alzheimerbc.org, you can find much more useful information and links to support and education opportunities throughout BC. If you have questions about information you've heard here or any other questions about living with dementia, please don't hesitate to call our FirstLink Dementia Helpline. English services are available Monday to Friday between 9 a.m. and 8 p.m.